Good morning friends, welcome back to my YouTube channel Medical Classes by Dr. Srinidhi Kumar Acharya. Please don't forget to subscribe to my channel and also please give your valuable comments. You can also visit the playlist. In the playlist I have provided almost all the topics in a very systematic order and this is quite convenient for the continuous study. I hope you will make use of it. Thank you very much. My dear friends, as we are discussing about the bleeding and clotting disorders in children, in the last class we have seen some of the important screening tests conducted for the identification of the platelet problems and as well as clotting factor problems. So today we shall have the continued portion of the same, where understanding the role of different coagulation studies in clinical scenario. What is the role of different coagulation factors studies in the clinical scenario? First, in case of coagulation disorders, the bleeding time, CBC, PBS, PFA are normal and either the prothrombin time or PPTP are abnormal. That means you are getting a clinical scenario where bleeding time is normal, CBC is normal, PBS is normal, PFA is also normal. Either the prothrombin time is get affected or APTT is get affected, abnormal. So now, if this is the case, definitely there are various coagulation disorders. If only APTT or PTPT is abnormal, but PT is normal, prothrombin time is normal, then it is the coagulation disorders of the intrinsic pathway involving the clotting factors like 8, 9, 11th and 12th. Okay? So because APTT or PTPT, they both are same, so that is get affected. So therefore it is a disease of the intrinsic pathway, one possibility. Second one is it may be also the von Willebrand's disease. Why? Because von Willebrand factor is also important for the stabilization of the factor number 8. So if the factor number 8 is not stabilized properly, then it is not able to activate the next factor, factor number 9, and again the problem starts. So when APTT is increased or abnormal, then it is definitely either the intrinsic pathway disease or it may be a von Willebrand disease. Again, if the child is having severe bleeding, then it is either factor 8 or factor 9 deficiency. Suppose APTT is increased, okay, but now child is having actually severe bleeding, then the possibility is that either it is factor number 8 or factor number 9. Okay, factor number 8 is true hemophilia deficiency causes, which causes hemoarthrosis, okay, like hemophilia A and hemophilia B. Now factor number 8 is a true hemophilia A, factor number 9 is a hemophilia B. So this is again pointing towards the hemophilic disease. Now PTPT, APTT, PTPT or APTT is prolonged and the bleeding manifestation is mild or moderate. See, one possibility is there, APTT is prolonged and child is having severe bleeding. Now the most common possibility is either it is a case of factor 8 or factor 9 deficiency, which is called as hemophilia A or hemophilia B, which causes severe bleeding. Second possibility is a scenario is where APTT is prolonged but bleeding is mild, not very severe. Then most probably it is factor 11 deficiency, which is nothing but hemophilia C. In case of hemophilia C, factor 11 deficiency, there will not be any severe bleeding or moderate bleeding, there will be only mild bleeding will be there. And if the child is asymptomatic totally, if the child is totally asymptomatic and coincidentally we found that APTT is increased, intrinsic pathway problem is there, but the child is not having any bleeding so far, any internal bleeding so far, there is totally asymptomatic condition, then we have to think about factor 12 deficiency, first factor which is get activated, factor 12 deficiency or prokallikrein or HMW kinogen deficiency. So this is when the child is totally asymptomatic but APTT is increased. And if the PT is prolonged, no doubt, if the PT is prolonged and PPT is normal, APTT is normal, APTT or PTPT is normal, but PT is prolonged, yes, PT is increased, then it is definitely a disease of the extrinsic pathway. Factor number 7, factor number 10, okay, then 1, 2, 3. So most commonly factor 7 deficiency. Now if the PT and APTT both are abnormal, APTT, PTPT or APTT, they are one and same, okay, don't confuse it. So if the PT is increased, abnormal, and APTT is also abnormal, then it suggests the common pathway involvement, okay. So both intrinsic pathways also get affected, extrinsic pathways also get affected, both the factors mesh together at the factor number 10, okay. So therefore it suggests that both are abnormal, so that means it suggests that common pathway involving the factor 5, 10, 1 and 2. Then we have to do TT. TT means thrombin time, and RT. If this is a situation, both are increased, then it suggests that mixing pathway, common pathway problem. In the common pathway, to identify the problems of the common pathway, we have to go for thrombin time and also RT, recitin time. If thrombin time and recitin time both are get prolonged, okay, then child is having factor 1 deficiency. Factor 1 is fibrin, factor 1 deficiency, okay, if both are getting increased. So this is seen in congenital afibrinogenemia or dysfibrinogemia. Congenitally afibrinogenemia, fibrin itself is absent, fibrinogen itself is absent, so there is no question of conversion, okay, or dysfibrinogemia, it is abnormal. So this is a case when thrombin time is also increased and RT time is also increased. Now if the thrombin time is prolonged but RT time is normal, then it is due to the heparinization. Heparin is usually given or for the clotting purpose, okay, so to as an anticoagulant. So heparin is given, or we have collected the sample in the heparin bottle. This is also possible. Suppose for the coagulation profile, you have collected the sample in the heparinized sample bottle. Then heparin definitely causes anticoagulation action. Okay, it's known for its anticoagulant action. So this is possible if the TT is prolonged but RT is normal. If both are abnormal, then factor number 2, 5 and 10 deficiency will be there, common pathway, or it may be even vitamin K deficiency. It may be even vitamin K deficiency or liver disorder or DIC, disseminated intravascular coagulation. Now if in a patient PT, extrinsic pathway, and APTT, intrinsic pathway, and thrombin time is for the common pathway, thrombin time, all the three are get prolonged. Then we have to go for mixing study. In this, after doing mixing study, if PT and APTT or TT are not corrected, even after doing the mixing study we have explained in the last class, we have to add the normal plasma to the patient's plasma, isn't it? So after doing the mixing study also, these three are not get corrected, they are as if, then it suggests that there are some inhibitors are there. Okay, So we have to rule out some of the inhibitors. So like we have to rule out the disorders like lupus, anticoagulant in SLE, or some of the viral infections in HIV, etc. we have to rule out. Now if the prothrombin time and APTT and TT are get corrected, all the three are get corrected after doing the mixing study. Okay, so that means that child is having clotting factor deficiency, any one of or all. So mixing में जो आता है factor number 10, then come 1, 2, 3. So these, any of these deficiency will be there because after doing the mixing study it is corrected. That means any one of the factor is get absent or deficient. Now suppose all the screening tests are normal. Okay, all the screening tests are normal, then we have to go for the clot solubility test to rule out the factor number 13 deficiency. Now factor number 13 is there, that is factor number 13 is called as clot stabilization factor. Bleeding is going on, but all the screening tests are normal related to extrinsic, intrinsic pathway, everything. Okay, then we have to rule out the factor 13 deficiency. If it is also normal, suppose factor 13 is also normal, then we have to go for chromogenic assay. Because sometimes child may have alpha 2 antiplasmin deficiency. If the child will have alpha 2 antiplasmin deficiency, so this possibility is there, bleeding will be there, plasmin deficiency is there, so bleeding will be continuous, but everything is normal. Sometimes mild hemophilia and mild Wilbrand's disease also present with the bleeding manifestations, and screening test is not able to detect this. Hemophilia is there but not up to the mark, mild, or von Willebrand disease is there, not up to the mark, mild. So bleeding will be there but not able to diagnose what actually the problem is. Okay, sometimes all the screening tests are normal, then we have to see the blood vessel disorders. Suppose all the screening tests are normal, we have to also look into the blood vessel disorder. So these blood vessel disorders may be congenital, like hereditary hemorrhagic telangiectasia or Ehlers-Danlos syndrome, or some of the disorders like acquired disorders like HS purpura, and some of the autoimmune disorders, HS purpura, scurvy, Cushing syndromes, etc. So that means we have to also look into it. If everything is normal, coagulation profile is totally normal, but this may be also the possibility for the bleeding. Now, if the child is bleeding and not having coagulation disorders, child is having bleeding, but on investigation there is no any coagulation disorders, that is PT, APTT and TT are normal, but he is having bleeding. Then now we have to think about the platelet disorders. Yes, there may be platelet disorder, because platelets are also equally responsible for the formation of the temporary plug, hemostatic plug, isn't it? So now we have to concentrate on bleeding time and platelet count. If the child is having thrombocytopenia, which is very common in children, thrombocytopenia, and if the bleeding time is prolonged, then think about congenital thrombocytopenia, or even sometimes idiopathic thrombocytopenia. Or you have to also think about impaired platelet production, and we have to also think about destructive thrombocytopenia, and we have to also think about sequestration. See, these are the possibilities when all the clotting factors is normal, extrinsic pathway, intrinsic pathway, everything is normal, but still child is bleeding. Okay, we have ruled out so many other congenital problems also. It may be a simple platelet disorder. Okay, we are concentrating only on the clotting factor now, but it may be platelet disorders. Platelet count is normal, may be decreased. Platelet quality may be decreased. Platelets quantity may be decreased, or there may be some other congenital problems. Now, if the child is having a normal platelet count with the prolonged bleeding time is increased, but if you see the platelet count is normal, then think about the platelet functional disorders. That means quality of the platelet may not be up to the mark. Quantity wise it is showing the normal count, but it is not able to render its function normally because the quality wise it is very low. So like there are some disorders like inherited disorders like Glasman's thrombobasthenia, von Willebrand disease, or acquired conditions like intake of the drugs like aspirin and clopidogrel, and as well as uremia like condition. Now if the child has got thrombocytopenia, platelet count is decreased, thrombocytopenia, and BT is prolonged, bleeding time is prolonged, then look at the clinical appearance of the child. Okay, if clinically child is looking well, or if the child is clinically looking very sick, so that you have to observe. Now thrombocytopenia is there, platelet count is decreased and BT is prolonged, child is looking well, and then see the morphology of the platelets. Okay, if the platelets are of large size, then either we have to rule out the immune thrombocytopenia like idiopathic thrombocytopenic purpura, SLE, drugs or HIV, and if non-immune that is 2B or platelet type von Willebrand's disease or macrothrombocytopenia. If the size of the platelet is small than the normal, then it may be certain congenital problems like TAR, VOS, Fanconi anemia, etc. Or it may be also due to some of the acquired conditions like medications, toxins or radiation. This is if the child is looking normal, child is looking well. BT is prolonged, thrombocytopenia is there, child is looking normal, active, sick, there is no sickness. Then these are the possibilities. But if the child is looking sick, thrombocytopenia is there, BT is prolonged, child is looking sick. And if the size of the platelet is large, okay, if the size of the platelet is large with the increased PDP, FDP, then there may be microangiopathy, HUS, TTP, DIC, thrombosis, neonatal sepsis, etc. should be considered. And if the child is sick with the size of the platelets are very small with hepatosplenomegaly, then you should also think about the malignancy and some of the storage disorders. If the platelet count is normal and BT only is prolonged and PFA is 100, then think about the von Willebrand's disease. Von Willebrand factor is to AG level, so that we have to see. Okay, so this is how clinically we have to approach. Now look into some of the cases. Question number 1. A 7-year-old boy had complaints of prolonged bleeding after tooth extraction. Dentist was worried and advised the coagulation study. Coagulation study shows normal bleeding time with prolonged PT and ATPT. Prolonged PT and both extrinsic and intrinsic both are increased. And there is also increase in the TT and RT time. Okay, that is also increased. Which of the clotting factor deficiency is this? Anybody? See, extrinsic, intrinsic pathway both are get affected. In the meantime, TT is also raised and RT is also raised. So factor number 1, 2, 3, 8. 8 is not the possibility. Factor number 1, 2, 3. So this comes under the common pathways. Definitely this is a disease of the common pathway because both are increased. PT and APTT both are increased. And meantime, TT is also increased. So any factor 1, number 1, 2, 3 deficiencies may be there. Another question, child of 6 years complains of delayed coagulation after trauma and APTT is prolonged and the bleeding manifestation is mild to moderate. So APTT is prolonged means it is an intrinsic pathway. In the intrinsic pathway we will have 11, 10, 9 and all the factors given in the option is of the intrinsic pathway. The only clue is they have given mild to moderate, very mild. So it is not factor number 8 or 9. So possibility is factor number 11. In factor number 11, both are increased. APTT is increased, bleeding time is also increased, but the presentation is mild. Whereas in 8 and 9, the bleeding will be very severe. 8-year-old male patient come with the moderate bleeding. PT, APTT and TT are prolonged. Okay. Then what investigation that you suggest? 8-year-old male patient came with moderate bleeding. PT is increased. Okay. Extrinsic pathway. APTT is increased. Intrinsic pathway. TT is also prolonged. Thrombin time. That means it is a mixed pathway, common pathway. Now they are telling that which investigation, asking that which investigation you suggest now. Yes, definitely it is mixing study because common pathway is increased, isn't it? Therefore, you have to go for the mixing study. Child had fever since last 8 days, which comes in interval of 8 hours. Okay, rhythmic and child is the fever is rhythmic. Okay, child is well in interfebrile period. This is definitely in a viral fever, no doubt. In the viral fever, child is well in interfebrile period. And then he also started the bleeding spots in the body and also the joint swelling. Okay, bleeding spots are also there and joint swelling. Joint swelling suggests of hemoarthrosis. Bleeding spots they are telling, that means it may be also the petechiae, etc. On investigation, PT or APTT and TT were prolonged. Okay, all the three are prolonged. Then pediatrician advised for the mixing study. Yes, definitely, right thing. If PT and APTT or TT are corrected after this investigation, what it suggests? Yes, that we have seen. If it is corrected after this investigation of mixing study, either there will be deficiency of a factor number 1, 2 or 3. And after mixing study also, if it is not corrected, then it suggests there are some inhibitors. Very good. Question number 7. Now, if only APTT is abnormal but PT is normal and the child is presented with a severe bleeding from the gums and nose, he also has hemoarthrosis in the joint with a normal bleeding time, what are the possibilities? There is severe bleeding, intrinsic pathway, hemophilia A and hemophilia B, both can cause this. Okay, hemophilia C or factor number 11, it causes mild bleeding. Von Willebrand's also cause mild bleeding. Okay, so these are some of the questions related to this clinical application of the coagulation profile. And the next class onwards, we will see one of the very important diseases of the intrinsic pathway, so that is hemophilia. Thank you very much.